Good morning, everyone. My name is Andrea Jakubowski. I'm a third-year medical student, rising fourth year at Lake Erie College of Osteopathic Medicine in Erie, Pennsylvania. And today I'm going to be presenting my manuscript titled Pediatric Peanut Allergy Trends Following the 2017 AAP Guidelines for Early Introduction and Patterns in Food Allergy publication. Do I have to point it anywhere, or? Oh? It's not switching on here. Okay, now I think it's switching. Okay. So peanut allergy is an extremely common allergy in the whole population, particularly in children. It's also very dangerous. Anaphylaxis is something that is very concerning for patients and parents of children who have peanut allergy. Interestingly enough, the rates of peanut allergy have tripled within the last 2 decades, creating a significant public health concern. Unlike milk or egg allergies, peanut allergies don't really typically resolve, and less than a third of kids tend to outgrow this allergy by adulthood. So about 65–67% of adults will persist this allergy into adulthood. So this persistence combined with the risk of this fatal anaphylaxis is why finding an effective preventative strategy is so important. Press it again. Okay, I might just keep this open as long as that's okay with everyone.
Just say next and I'll do it for you.
Okay, that works. So the timeline of how allergen introduction was advised is kind of interesting. So in 2000, the AAP had recommended completely delaying peanut introduction until the age of 3. By 2008, avoidance was determined to not really be helping, and subsequently in 2015, the Learning Early About Peanut Allergy trial supported by the National Institute of Allergy and Infectious Disease reversed this course, proving that early dietary exposure actually helps children build tolerance. This eventually led to the 2017 NIAID addendum, which is the current gold standard for allergy introduction. Next. So this LEAP trial that was published in 2017 is our foundation for the current policy. So the findings of this trial suggest that high-risk infants, which are those with eczema and egg allergy, that introducing peanut snacks and peanut-containing foods those children are three times a week, drastically cut the allergy rate in these children. The difference in allergy rate was extremely profound. It was roughly 2% in children who had been advised to introduce peanut-containing foods early, as opposed to 14% of those who, no, it's okay. Yeah, that's good. Thank you. Versus 14% of those who did not. And thus the incidence of peanut allergy was very significantly different between these two groups. So this changed our theory from being introduction of avoidance prevents sensitization to exposure helps create tolerance. Next, please. So despite this trial's success, the population level impact and what happens in the real world is what is extremely important. Our objective for this study was, did the 2017 guidelines truly shift this curve of peanut allergy incidence in the real world, where implementation might be inconsistent? We used data up to 2025 to give enough time for a biological effect to manifest. Okay. For this study, we used the TriNetX data network, which is a database of longitudinal electronic health records. This, additionally, we used interrupted time series analysis, which helped us statistically model the trend before the intervention, again, which was in 2017, and see if that slope in peanut allergy incidence changed after the intervention. The year of 2017 itself was excluded to be considered as a transition period. and permit for guideline rollout. So this chart helps us observe the raw incidence proportion of peanut allergy incidence over this timeline. That dotted line that you see vertically throughout the screen represents 2017, which is going to be that transition year that was excluded from the study. So overall, you can see kind of this steady incline in incidence from 2012 to 2025 overall. In 2012, about 121 children per 100,000 children were diagnosed with peanut allergy for the first time. That's roughly 0.121%. By 2025, that number hit 259 children per 100,000, roughly 0.259%. So visually, looking at this curve overall, there's not an obvious significant, there's a couple dips and plateaus, but there's no significant drop-off, and there's no significant level off. Especially after the red dot, which represents, again, that 2017 guideline rollout period. So looking at the numbers, the mean incidence proportion was 0.146% pre-guideline versus 0.2% post-guideline. While the number of cases grows with the database size, the proportion is going to be our key metric here to really be able to measure the difference between these time periods. So our post-guideline peak of 0.259% in 2025 suggests that the absolute risk of being diagnosed with peanut allergy in this age group is persisting to climb. So these statistics help kind of confirm what we were visualizing on that graph on the previous screen. So while there was a significant upward trend before the guideline period, which our P was less than 0.05, there was absolutely no significant immediate change in the long-term shift in the rate of increase, which is depicted by our slope following 2017. Statistically speaking, the intervention of the guidelines did not significantly alter the course of new peanut allergy diagnoses through the year of 2025. So kind of looking at why did this not work per se? Why didn't we see this change following the guideline implementation? First, worth considering is a biological lag. So a child born in 2017 only reaches the upper limit of our study, which is the age of 4 years, in 2021, potentially not permitting enough time for that benefit per se to manifest. Second, implementation barriers do exist. So a trial as a controlled environment doesn't necessarily depict real-life environment. Additionally, we must consider if known environmental triggers are outpacing our preventative efforts, which is something that we'll touch on here shortly. Something that was pretty interesting looking at data for this study is provider implementation. So this seemed to be a significant barrier to true implementation and adherence of the guidelines. 97% of specialists in some studies reported knowing that these guidelines existed, while full implementation dropped to 64% for allergists, and that number drops as low as 14% for pediatricians. If the frontline doctors, these are going to be these main providers that these children and families are seeing, if they're not consistently suggesting this advice during the critical 4 to 6 month periods during well checks, this policy won't succeed. Second barrier is parental fear. So parents tend to naturally be scared and worried for their child, and especially their health and safety and well-being. About 32% cited a fear of reaction as being their main reason to wait to introduce peanut-containing foods and not introducing them early. Furthermore, many parents also viewed early introduction as just being a test to see if their child even had the allergy, as opposed to being a preventative strategy. This is a fundamental misunderstanding leading to hesitation and missed opportunities during a critical window of tolerance in this age. And something I mentioned earlier is going to be our environment. So our world is changing, and studies have demonstrated that increased pollution, excessive antibiotic use, and vitamin D deficiencies are all linked to higher allergy rates. It's possible that these 2017 guidelines actually really are preventing peanut allergy. However, there's environmental risk factors that are also at play that may be mitigating or negating this benefit. And the role of awareness. So there is diagnostic vigilance among clinicians and parents that has improved, which is improving detection rates in previously undiagnosed or silent cases. Something else to consider here is that there was a 2015 transition to ICD-10 coding and subsequent diagnostic updates in 2020 that may have enhanced the visibility of EHR data without a true rise in biological incidence. Hence, there may have been more correctly diagnosed peanut allergy cases that were actually manifested sooner. So, as we all know, no study is perfect, right? We rely on things like electronic health records, especially for this study. They don't always tell us if the parents followed the advice, and they also don't tell us if this is a true allergy incidence, or true allergy diagnosis, excuse me. We also can't separate whether this policy truly failed or was there really just a lag, was there a biologic lag in the guideline implementation. So for future research, it is worth looking at cohort studies that track true feeding behavior alongside clinical outcomes to see if we're truly waiting for the results to catch up. So overall, our conclusion for the study is that clinical success in a trial does not really tell us what the real-world population level impact is going to be. There seems to be in this study particularly a gap between efficacy of these guidelines and effectiveness in the real world. So in order to look into the future, it's worth looking further into data and in cultural and educational outcomes for both doctors and parents to see whether this incidence trend is changing or not. Here are my references. Any questions? Thank you. Thank you.
So now we have Rahul Patel. He is going to be giving the second place presentation. Could you please give a round of applause for Rahul?
It's not mine.
Sorry, guys.
All right. So my name is Rahul Patel. I'm a second-year medical student at Torrey University, Nevada. And today I'll be presenting our systematic review and meta-analysis on the safety and analgesic outcomes of NSAID use after transoral robotic surgery. So the practical question behind this project was basically, after TORS, can we use NSAIDs to improve pain control as well as reduce opioid prescription and reliance meaningfully without increasing postoperative hemorrhage risk? And although the question sounds simple, bleeding is a major concern, regardless of the surgery, minimally invasive or an open approach. So, yeah. So, TORS has become an important minimally invasive approach. However, I think it's important to note that minimally invasive from a surgical standpoint does not mean the same thing for a patient who can misinterpret it as maybe less pain or something like that. Although there might be less pain, it's still important to acknowledge the opioid dependency that happens after transoral robotic surgery. So just a couple quick notes about this. Historical standard, the historical standard has been opioid analgesics. However, recent trends toward multimodal analgesia have been important for reducing opioid reliance. It's important to note that even though the surgery is minimally invasive, the wound is in an area that constantly moves during swallowing, feeding, hydration, and so those are all painful outcomes for somebody who may be looking to improve and be discharged. So that affects, like I said, oral intake, hydration, swallowing, discharge readiness. And historically, opioids have been used. However, they come with major downsides, such as respiratory depression, sedation, constipation, and they eventually end up just delaying recovery. So, the clinical dilemma that this study hopes to address is essentially that ERAS pathways support multimodal analgesia to reduce opioid exposure, and NSAIDs are attractive because they're both analgesic and anti-inflammatory. But after TORS, the concern is postoperative hemorrhage from a surgical standpoint and from a patient standpoint, and mechanistically, the concern is that non-selective NSAIDs impair platelet function through COX-1 inhibition, and clinically, bleeding in the oropharynx can be frightening, difficult to manage, and potentially life-threatening. So the dilemma here that we're trying to balance is improving pain control and reducing opioid reliance while not increasing hemorrhage risk. Yeah. So so the research objectives were to analyze the safety and analgesic outcomes of NSAID use after TORS. The primary focus was postoperative hemorrhage, and we essentially wanted to provide some high-level evidence to inform definitive pain management strategies, and the impact would eventually be reduced to opioid reliance. So our study design was a systematic review and meta-analysis. It was in adherence with PRISMA, and the inclusion criteria were postoperative NSAID use in any manner, whether it be part of multimodal analgesia or isolated studies showing extractable hemorrhage and analgesic data. Exclusion criteria were obviously non-TORS populations, non-English text, study designs without extractable outcomes. We searched PubMed, Embase, and Scopus from inception to February 2nd, 2026. The primary outcome, like I said before, was postoperative hemorrhage. Secondary outcomes were 72-hour pain scores, opioid consumption, and discharge prescribing. The risk of bias was evaluated by Robbins 1, version 2, for retrospective and comparative studies. Case series appraisal was done by Joanna Briggs Institute. And all software and statistical analysis were performed using R. Statistical modeling was random effects models for hemorrhage and standardized mean differences. Sensitivity analysis. So the two sensitivity analyses that I wanted to look at prior to even approaching the study were things that would affect bleeding and cause confounding risks. That would be external carotid artery ligation, as well as selective COX-1 versus COX-2 inhibition. So in this case, that would be celecoxib, because in that case, that would alter the mechanism of bleeding. And so we'll get into that. The search yield was 500 records. Essentially, by February 2nd, there were 7 papers. After February 2nd, there was a 8th paper that was released, and that included in the study. The NSAID cohort was 1,147 patients. The clinical profile is predominantly male and HPV positive oropharyngeal tumors. NSAID agents were celecoxib, which is COX-2 specific, ibuprofen and ketorolac, which are general NSAIDs, along with mixed NSAID use as well. So for those, I was not able to do a statistical analysis to assess the differences, but we will get into that. So the overall incidence for the pooled postoperative hemorrhage rate was 8.31%. Historically, this remains within the expected 3 to 9% in the literature currently. And since sensitivity analysis was done to exclude prophylactically ligated external carotid arteries. And this rate reduced to 6.77. So this is actually interesting. You would expect, if you were to remove external ECA ligated patients, that you would see an increase in bleeding risk. However, we saw the opposite. So this goes to show that much more is at play here, including surgeon preference, patient history, and things of that nature. So I chose to do an exploratory analysis of COX-2 selective versus non-selective COX agents. And so the pooled postoperative hemorrhage rate for celecoxib was 6.37 versus non-selective was 9.76. Statistically, there was no significant difference, although you could see that there is a slight increase in rates between the two. So what I wanted to analyze also was in those studies that compared NSAID-containing regimens to those with primarily opioid-containing regimens, I wanted to look at the primary outcome for postoperative hemorrhage, and we found that NSAIDs did not significantly increase the risk of postoperative hemorrhage. The risk ratio was 1.56 with low heterogeneity. Clinical insight, so the data suggests that perceived risk of NSAID-induced bleeding in TORS is likely overstated, just because there was no significant difference found. Reported events were often minor. So that's another thing to consider too, is the bleeding definitions by different cohorts that were analyzed. And that's part of the limitations of this study, is that a minor bleeding event is not the same as a major OR bleeding event. And so that's also important to consider. Secondary outcomes that were looked at were 72-hour pain scores, 72-hour opioid use, and opioid stewardship as well. So what we found was that pain was reduced, and opioid stewardship was also reduced in NSAID-containing cohorts. The analgesic benefits were achieved without compromising overall surgical safety. So it's important to note here that what we found about opioid prescriptions at discharge, which was that mixed multimodal analgesia cohorts were less likely to require opioid prescriptions at discharge. So not only does this go towards patients who are themselves, but also towards the community as well. So if you are able to prescribe less opioids to your patient, less untaken pills are out in the community for others to acquire. So there was a significant, substantial decrease in discharge opioid reliance. Findings align with the AAO-HNS current recommendations for using NSAIDs as first-line postoperative therapy. The impact is, like I said, reducing discharge narcotics, mitigates long-term dependence and respiratory depression. So our results were analyzed by Robbins version 2, as well as JBI, where appropriate. So one study was rated as low, and 3 were a serious risk of bias, but this was largely just because of domain 1, which was because non-randomized treatment allocation. So these were just retrospective cohorts, and this is part of the issues that come along with analyzing them. And then case series were all done by Joanna Briggs Institute. Yeah, so this is part of the analysis of the discussion. And so the point about the bleeding, major versus minor, is critical because a minor self-limited bleed and return to OR hemorrhage are not the same event. But a lot of studies report them under the same umbrella. So it is hard to distinguish between the two. The most balanced interpretation is that NSAIDs were not associated with a statistically significant increase in postoperative hemorrhage, and the perceived risk at the current state is that NSAID-induced bleeding after TORS is likely overstated. So yeah, like I said before, celecoxib is currently valued for avoiding COX-1-mediated platelet impairment. And there was no statistical significance in the exploratory analysis that I found between the two. Exploratory analysis suggests that, well, I should say that celecoxib cohorts were also small and confidence intervals were wide. So it's hard to set apart celecoxib from other NSAID-containing cohorts in that sense. So future studies should report NSAID agent, dose, route, start day, and duration, because NSAID exposure is not one uniform intervention. And to build upon this, celecoxib, like twice daily, is different from IV ketorolac every 6 hours, and that's different from scheduled ibuprofen. And so these differences are important to keep in mind. And finally, the next question is not just that NSAIDs, yes or no, but it's which NSAID for which patient at what time and in what surgical context. So these are the current AAO-HNS clinical guidelines, or I guess as of April 2021. And findings directly support their national guidelines in identifying NSAIDs as the first-line therapy. Results currently validate the transition of to MMA from opioids as a necessary strategy to reduce narcotic reliance. And NSAID-containing multimodal pathways improved pain outcomes, opioid reliance was reduced, and like I said before, postoperative hemorrhage was not increased. Optimizing pain control targets functional goals, like earlier diet advancements and shorter hospital stays, so this is all good for the patient. So some of these I've already talked about before, but the predominance of retrospective cohorts introduces potential confounding and selection bias. The studies were, so only 8 studies were also met for inclusion criteria, and fewer contributed to each pooled outcome, right? So that's also important to keep in mind where we just have a limitation of data currently. Thankfully, to databases such as TriNetX, we were able to actually find papers that increased our N count, so I was able to make a little bit of a stronger case for our findings. Third, as I talked about before, NSAID protocols varied by type of NSAID, when it was used, the route, duration. Fourth, analgesic outcomes were reported very rarely. So a lot of the conclusions that we drew were based on 2 to 3 cohorts that were analyzed. And obviously pain scores per study are ranked using a different way too. So we had to find a way to kind of aggregate and come up with a way to analyze these studies as a whole. Fifth, bleeding severity was inconsistently defined. So like I said, it's important to distinguish for future studies what a major and minor bleeding event is. There's, for example, one study that had 5 minor bleeding events for those taking NSAIDs and 1 major bleeding event for those not taking NSAIDs. And so, that can shift the analysis in certain directions. And finally, prophylactic ECA ligation was often reported at a cohort level. So the largest paper that we analyzed discussed ECA ligation as a part of neck dissection. And so they made the equivalence in terms of the rates between the two. So it's important to note that we did not analyze ECA ligation outcomes based on whether they were ligated or not. And so future studies should use prospective multicenter TORS analgesia protocols with standard reporting of NSAID exposure, bleeding severity, vascular control practices, opioid consumption, pain scores, diet advancements, and readmissions. So before I touch on the conclusions, because we are a part of the broader DO community, I wanted to touch on a couple points that I didn't include in the paper, but I felt were interesting to include as a discussion. So there's different DO techniques that could be used to improve drug delivery to the oropharynx for NSAIDs, as well as reduce blood flow as well. So those are 2 things that we could keep in mind after discussing with some of my OMM peers and professors. And so finally, to conclude, NSAID-containing regimens after TORS were associated with improved analgesic outcomes, lower pain scores, lower inpatient opioid prescription, and reduced discharge opioid prescribing. So from a safety standpoint, NSAIDs were not associated with statistically significant increase in postoperative hemorrhage. Overall hemorrhage incidence remained within expected historical ranges from 3 to 9%, suggesting that perceived bleeding risk of NSAIDs after TORS may be overstated. The take-home message is not that every patient should automatically receive NSAIDs. The take-home message is that NSAIDs appear to be safe and an effective component of a carefully designed multimodal analgesic pathway after TORS. And they deserve continued integration and prospective study as we continue to optimize recovery and reduce opioid reliance. Thank you, and I'm happy to take questions.
Hi, good morning, everyone. I would like to start by thanking the AOCOO HNS Committee for the opportunity to present our work. For those I've not had the privilege to meet yet, my name is Jonathan, and I'm a rising fourth year medical student at PCOM Georgia and a clinical research fellow at the Medical University of South Carolina. Today, I'll be presenting our study examining the association between osteopathic manipulative treatment, or OMT, and early opioid prescribing patterns in adults following diagnosis of temporomandibular disorder. I have no financial disclosures. So temporomandibular disorder is actually the leading cause of chronic orofacial pain, and it affects up to 1/3 of the world's population. A substantial portion of these patients enter the healthcare system by seeing otolaryngologists, as there are overlapping otologic symptoms, including otalgia, oral fullness, or facial pain that may mirror structural otologic disease. The anatomic explanation is the auriculotemporal branch of the trigeminal nerve, which provides sensory innervation to both the TMJ and the external auditory canal. That shared pathway is why temporomandibular disorder may closely mimic otologic disease and why these patients may land in ENT clinics. However, our current guidelines are clear. The management of TMJ pain should be with conservative approaches, including a trial of NSAIDs, oral appliances, soft diet, behavioral modification, and physical therapy. Opioids are not recommended by any current guideline. However, opioid prescribing in temporomandibular disorder still occurs, and critically, it tends to occur early in those first few encounters when the diagnosis is uncertain and pain is undertreated. And that is the gap that we aim to address with our study. If opioid exposure and temporomandibular disorder is concentrated in the early treatment period, then early interventions that reduce uncontrolled pain may reduce downstream prescribing. OMT is a plausible candidate for exactly that role, but whether OMT is associated with reduced need for opioid pain control and real-world TMD care has not been examined at scale. As we all know, OMT is a physician-delivered, hands-on treatment targeting musculoskeletal dysfunction. In TMD, the relevant regions typically include the head, the cervical spine, and often even the thoracic cage, given their musculoskeletal interdependence. The mechanistic rationale is straightforward, and many TMD patients have overlapping cervical dysfunction, myofascial pain, bruxism, and altered pain processing mechanisms. A treatment that addresses those somatic contributors directly may reduce the uncontrolled symptoms that drive escalation to pharmacotherapy. So our objective was to evaluate whether OMT exposure was associated with reduced early opioid prescribing in opioid-naive adults defined as no opioids within the previous 6 months and with a new diagnosis of temporomandibular disorder. We performed a retrospective cohort study using the TriNetX database, a federated research network that represents over 60 US participating healthcare organizations. Again, we included opioid-naive adults, and they all had a new diagnosis of TMJ, defined by the ICD-10 and 26 series of codes. And we had a group that received OMM and a group that did not receive OMM. And the way we tracked that was through the CPT code range 98925 through 29. And for those who aren't familiar, that code range represents number of areas of the body treated from 1 to 5. That's going to be one key limitation to our study, is that we can't tell you exactly which technique was deployed and exactly where it was deployed, only the number of techniques done. Okay, this is our patient population. And before we examine cohort balance, it's worth situating who these patients are and whether they reflect what we already know from the literature. And with consistent epidemiologic data, our TMD population was predominantly represented by females and those who are middle age. And women account for roughly 70 to 80% of cases in the literature. And the age distribution in our cohort was similarly consistent with peak representation in the 3rd through 5th decades. The comorbidity burden in our population was also notable. So anxiety and depression were prevalent, reflecting a well-documented overlap between TMD and psychological distress. Patients with TMD carry substantially higher rates of mood disorders compared with the general population. And those comorbidities influence both pain chronification as well as the risk of escalating therapy. Okay. So these are our primary results. So we looked at 30 days after diagnosis of TMJ, patients who were treated with OMT were associated with a 30% relative reduction in new opioid prescribing. 6.3% of patients in the OMT cohort received an opioid prescription, compared with a 9.1% rate in the comparison cohort that did not receive OMT. That difference is not trivial, and the risk ratio was significant at 0.70. This represents both a clinically meaningful and statistically significant reduction in early opioid exposure. We did an analysis looking at other time points as well, ranging from 7 days to 90 days after diagnosis and treatment with OMT or not. And that association persisted across every evaluated time point. The largest reduction was observed at 7 days with a risk ratio of 0.55 and remained significant all the way through our 90-day last endpoint. This was not a single window finding, and the consistency definitely provides additional evidence that we're observing a true effect. We also observed oxycodone prescribing specifically. So the code we used for our previous and primary analysis was any opioid exposure, but we wanted to do a sensitivity analysis with the most commonly prescribed opioid, which is oxycodone. And when we did that, we found a similar and consistent result. The association persisted again across every evaluated time point, and again, the largest reduction was observed early on. So this all brings us back to our original question. Is OMT associated with reduced early opioid prescribing in opioid-naive patients newly diagnosed with TMJ disorders? And based on these data, the answer is yes. OMT was associated with a meaningful reduction in early opioid prescribing, and the association is mechanistically plausible. TMD is often not simply a joint disorder. Many patients have overlapping muscular hyperactivity, cervical dysfunction, myofascial pain, and altered central pain processing. By addressing somatic dysfunction early in care, OMT may reduce the uncontrolled symptoms that drive escalation to pharmacotherapy. That is the optimistic interpretation, but there are two very important limitations that we must show attention to. First is the provider effect. So OMT can only be billed by osteopathic providers, and as a result, OMT represent encounters that reflect a different type of clinical visit. These patients may receive more time, they may receive more hands-on assessment with more emphasis on multimodal and conservative care. And so the association we are observing may reflect a practice philosophy difference, a difference in prescribing behavior or patient selection, as much as the mechanical intervention itself. And the second limitation we must consider is misclassification. So again, CPT codes only capture that OMT was performed and to the number of body regions that it was performed. But we cannot tell you which technique, which region, or with what intensity the patient received treatment. And so we can't identify a superior treatment for TMD. There are many. So we cannot separate these pathways in an observational data set, and we are not claiming causation on any level. However, when an association like this is as substantial as we see, and it's temporally consistent and biologically plausible, it does warrant further prospective evaluation. And for otolaryngologists, it's a particularly relevant point, as they often encounter these patients before prescribing patterns are established. And that is a window of opportunity for osteopathic trained providers. In conclusion, in opioid-naive adults with newly diagnosed temporomandibular disorder, OMT exposure was associated with lower early opioid prescribing, including a 30% relative reduction at 30 days, and similar associations were observed across multiple additional time points. This is the first large-scale real-world study examining the relationship in TMD care with OMT and the opioid utilization rate that follows. Prospective trials are needed to establish causation. But these findings do align with a principle already familiar to this audience. When pain is addressed early, thoughtfully, and conservatively, subsequent opioid exposure may be reduced. Early care pathways matter, and the choices made in those first few encounters may shape outcomes well beyond that initial visit. I would like to acknowledge and thank my co-authors and collaborators, Dr. Carl Shermatero with McLaren Health in Oakland, as well as Dr. Desiato at Lehigh Valley, and Dr. Sean Nguyen at the Medical University of South Carolina. Thank you all, and I'm very happy to address any questions you may have. Any questions? Okay. Well, thank you all for sitting patiently. I smell breakfast, so enjoy.